patient in my video has an L1 Asia A spinal cord injury. This means that he has no innervation of sensation or motor control below the L1 level. Patients with this injury, they do have partially innervated psoas, and all their upper body extremities and trunk should be innervated. So this patient will be independent with any bed mobility, independent with wheelchair skills, and independent with transfers. For gait, this patient will need some assist or be independent, but he has to be using KAFOs along with another assistive device like a walker or forearm crutches. The functional task that my patient is doing in the video is a sit to stand, and then a stand to sit. In the parallel bars, getting out of his wheelchair, and he has a therapist in front of him guiding him and helping him do the movements. So for this patient's neurological level of injury, what he should be able to do for the optimal way that he would stand up with the two parallel bars next to him is he would first obviously have the brakes on his wheelchair, and then he would lock out his KAFOs. So let's imagine that I have my KAFOs on and they're locked out straight in front of me. He'd be positioned at the edge of the wheelchair, and then he'd put his hands up on the parallel bars like so. From here, what he's going to do is he's going to keep his trunk flexed, and he's going to push down to lift his butt up off the table, or off the wheelchair, and then he's going to walk his hands forward to stand up completely. So I'm going to show you what he would do. So he's going to be here, he's going to push up, and then he's going to just walk his hands forward, like so, using the parallel bars as support. And then he's going to be standing like this. And then for when he's going to sit back down, he's going to do essentially the same thing. We want to have distance. You could probably back up a little bit, but we want to have distance between the patient and the wheelchair. This is because with the KAFOs on, when his legs are going to be locked out, if he's too close up against the wheelchair like we would normally do for most patients, he could possibly tip over the wheelchair when he goes to sit down. So what we're going to do is we're just going to walk our hands back again until we get to a comfortable spot where we feel like we have enough strength and control to lower ourselves down onto the wheelchair, where then we can reposition later. So I'll show you that. So we're just going to back up again, like so. And then we're going to lower the trunk down into the chair, and then they can reposition after that. So for my patient in the video, there was multiple things that he was doing that would make it harder for him to complete the sit-to-stand transfer. To begin with, he wasn't wearing his KAFOs. He didn't have any assistive device besides the parallel bars, and for him to be able to do any type of ambulation or anything, have any type of control, balance, he's going to need KAFOs on, because that will assist him with those muscles that he has no innervation to anymore, that is needed for postural stability. He also had decreased scapular depression strength and some tricep or shoulder strength when he was initially pushing up. He needed some assistance from the therapist to get up all the way. He wasn't able to push himself up completely. So that was at the very beginning of the movement that he struggled with that. And then kind of moving forward, he had some issues with the scapular retraction and trying to hold himself up while he was trying to straighten up. All of his movements were pretty much uncoordinated. He didn't have any smoothness to them, and he had decreased amplitude when he tried to make it all the way to the top to be standing up all the way. The therapist had to give him a little bit of help as well. Lastly, when he finally did get to standing, he didn't have, it might be trunk control was decreased, but his overall balance and stability was decreased. Even with the assistance of the parallel bars, he was having a hard time holding himself up and maintaining So now what I'm going to do is I'm just going to kind of show you what he was doing in the video and where his issues arise. So in the video, his legs were bent like this with his knees, and there was a therapist in front of him blocking the knees right away. He put his hands out to the side, and he could have possibly had them back a little bit more. You're not sure if he has more range of motion in his shoulders or not. You did figure that out due to your PT exam, but it might be something that we might need to work on if he can't go back any farther. However, he was here, and then initially when he first pushed up, he had a hard time getting up to here, which is where the therapist applied some help, where he's able to get up all the way to here, but then right here the therapist had to pull a little bit more to get him all the way to standing. And then once he wasn't standing like this, even with the parallel bars, he was swaying back and forth a lot, and he had to have the therapist helping him, giving him some assistance, probably min to mod assist, to help him maintain his balance throughout. And then when he went and sat back down, he kind of did the same thing where he just got here, but instead of doing a slow eccentric contraction to go down, he just plopped down. So for my patient, one thing that I thought would be very easy to do, just because he wasn't wearing KFOs in the video, is you could do just a donned off goal for the patient, because he's going to need to be able to independently put those on and off, know how to lock them, and how they kind of work to be as functionally capable as he is going to be able to. However, the two exercises that I'm going to choose to do for him is, one, we're going to do dynamic balance just within the parallel bars now, because that's what we were using in the video, and the patient was really struggling maintaining his balance while he was doing that. It will allow us to work on his balance when he's in standing, but it will also help him for when he does his sit to stand, when his legs are out in front of him and he has to walk his hands up. It'll help his balance throughout in those positions as well. And then the other one is the decrease in strength in the upper extremities, specifically the shoulder depressors and retractors, when he is doing the initial part of the sit to stand, and then throughout still walking his hands up. That will allow him to have better balance, better control, and even when then he's going back and sitting down, he'll be able to slowly lower himself instead of kind of plopping down in the chair. So those are the two exercises that I'm going to do for my patient. So the first exercise that I chose for my patient was dynamic balance and parallel bars. So here we have our parallel bars already set up. I would prefer that the patient would be wearing his KAFOs for this, because that will be what he's going to be needing to ambulate, and that's essentially what we're working on after this sit to stand. So just the exercise that I would do is I'd have him stand here using the parallel bars as support and practice just maintaining with his core strength and the muscles that he does have, trunk control and postural control throughout. To regress this activity, we could always have him in a different position. I'll use the parallel bar for example here, but he could be like this in a modified plantigrade position, just working on his balance as well, and we can do other exercises from this position as well. Along with, to progress the activity, I'd have him, when he's inside the parallel bars here, supporting himself, we could have him do weight shifts back and forth on his legs, also using his hands, because when he's going to be doing this at the stand and walking his hands forward, he's going to need to be able to weight shift and maintain control throughout. Otherwise, we could also have the therapist apply perturbations just to work on the dynamic control that he is lacking in the video. So the other exercise that I would do for this patient is strengthening for the scapular depressors. So one way to do this is you just have the patient seated on a mat. In this case, we use the chair. Can't use his wheelchair because he needs to be able to push off the ground or the surface that he's going to be sitting on. So what he's going to do is he's just going to be here. He's going to push up using his scapular muscles to hold himself up. We could hold for 5 seconds. Do that 10 times for 3 sets. You could mix it up, you could have him hold it longer, stuff like that. To regress this exercise, one way that we could do the same thing but regress it is we could have the patient lay supine, and a therapist would just be applying a force into his hand like this, and he would be pushing down into the therapist's hand. This would be less force than he would need to do it if it was too challenging for him. And then the last exercise or progression that I would do for this is when we have him do his scapular push-ups, essentially. When he gets up here, we could have him shift his weight back and forth, because that will simulate the scapular control and balance he's going to need when he is doing, when he's walking his hands up while he's trying to get up in the parallel bars or with his forearm crunches. So if he pushes up and he just goes back and forth a few times each side, do 3 sets of that as well. That would just make it more challenging on the patient and work on more functional components of that movement that he will need.